So rather than waiting, we can start the presentation with non-ratified member because your paper will not be judged. Okay? So this is not for the competition, but you can present. So I think you can start the paper. Dr. Roshan, you can start and give the presentation.
Good afternoon. I'm Dr. Roshan Christina, and I'd like to thank AIOC for giving me this opportunity to be able to present our research on the Pediatric Ocular Trauma Score, or the POTS. Now, we all know that ocular trauma is an important cause of ocular morbidity in children and young adults. And here we have an image of a young child who presented to our hospital earlier this year with a penetrating fishhook injury. Now, there are multiple factors which impact the final visual outcome in a penetrating ocular trauma. A few Indian studies have evaluated the association with these parameters, few of them being injury to surgery time, age, pre-op visual acuity, mode of injury. However, there is a paucity of data in the Indian setting, and hence we went about to study factors which influence visual prognosis and to compare the accuracy of POTS versus OTS in predicting visual outcome in ocular trauma. We went about by evaluating 20 children who presented to us with penetrating ocular trauma. We did a retrospective record review and studied them over a period of 3 years. And we followed up various parameters at 3 time points: 1 week, 1 month, and 3 months. These are the variables used to calculate the ocular trauma score, as we all know. These are the variables for the pediatric ocular trauma score. We have additional variables such as age and a very comprehensive list for the concomitant eye pathologies. Here I'd also like to highlight the equation for scoring, even in situations where the initial visual acuity is not obtainable. Coming to our results, we saw a range of penetrating eye injuries in children and noted that iris prolapse and vitreous hemorrhage were the most commonly associated ocular pathologies. Here, I'd like to bring your attention to the bar graph, where initial and final visual acuities are indicated in blue and orange respectively. So we could assess initial visual acuity only in 15 patients, and we saw that the majority of them presented with severe visual loss, and most of them continue to have severe vision loss, barring 2 who improved to moderate and 1 child who presented with moderate vision loss and improved to normal. Very importantly, sorry sir?
Time is 3 minutes, it's already over. You just conclude, give it.
Conclude. Okay. So here we have, very importantly, the initial visual acuity correlating significantly with the final visual acuity. And here we noted that the POTS score and POTS grade correlated with the final visual acuity, but the OTS score and grade did not. So what is the significance of our findings? We found that there's a need for a more integrated prognostic model such as POTS. There was a strong positive correlation between the initial and final visual acuity, as shown by other studies as well. And as compared to a more generalized OTS score, a pediatric specific scoring system proves to be a better prognosticator of final visual outcome. And my conclusion is POTS is a good predictor of visual outcome in pediatric penetrating ocular trauma, more useful than OTS. Thank you.
Thank you so much. So this is good. You are trying to bring something new.
Yes.
And this is restricted. This is there any other study where this POTS was being tried?
Yes, sir. So Indian studies, I have quoted 2 of them, sir. one by Dr. Rao, one by Dr. Agarwal Italia, but not too many in the Indian scenario, as I had mentioned earlier. International papers, there's one done in Turkey and another one which has been done in the US. But in this Indian scenario as such, there are papers on ocular trauma in adults, but not so much literature available specific to the pediatric population.
So, why you feel the difference? What is the specific to this POTS?
So, sir, can I would like to
Just tell me.
show.
It's
It's
okay,
okay, sir?
just
All right.
continue.
So, what we see in the POTS, sir, is one, age is taken into calculation, into consideration, which is not there in the OTS, and also the wound location. Now, age specifically is important here because in the pediatric population, it's a challenge to obtain the initial visual acuity. It could be false initial visual acuity, or probably because of communication issues in pre-verbal children, or because of restlessness in general, where it's difficult to obtain history or to do an ophthalmic examination. Also because prognosis in a developing eye as compared to an adult eye could also vary, which is why having a score more specific to the pediatric population will help to prognosticate better. And it's also shown in my scatter plot graph, sir,
I see.
because
Yeah.
I've compared the same score between an ocular trauma score and pediatric trauma score. So the same score proved to give a better visual prognosis for the pediatric age group as compared to the adults, and it correlated towards the end. And similarly, even for a poor prognosis, it correlated better than the OTS.
Yes, thank you.
Thank you, sir.
See, the OTS was designed so that anybody can see that patient and prognosticate accordingly. You know,
True,
it was
yes,
made
sir.
simple. But your POTS doesn't look so simple. Do you think that everybody will be uniformly doing the same assessment and evaluation in such cases?
So, POTS is also as simple, sir, because the only additional thing here is we're taking age into consideration, which I don't think is difficult to obtain, because even if the parents are, or the tender is there, we'll be able to get the age, or from documentation elsewhere, we'll be able to get the age. And the other thing is the pathologies. The ocular pathologies are going to be evidently visible to us. So that's another thing that's taken into consideration. Same thing with the wound location also. That's also something that is physically visible. So, and there's a special formula also, sir, which is not there in the OTS, because in the OTS, if you don't have the initial visual acuity, you can't even calculate, it's invalid.
Yeah.
But in POTS, there is a formula to calculate it even without the initial visual acuity.
Okay, thank you.
Thank you, sir.
Thank you so much. So
Thank
we'll go to the next first paper. Dr. Partha Rana. Dr. Partha, you are here. So we'll go to the next paper. Dr. Devdulal, please. Second paper.
Very good afternoon. I'll be speaking on role of preoperative anti-VEGF in altering the macular status in PDR with vitreous hemorrhage. Well, visual performance in diabetic retinopathy is mostly related to macular status. Hence, many a times, even after a successful vitrectomy in proliferative diabetic retinopathy with vitreous hemorrhage, visual performance is not good. This study evaluates the macular status with OCT 1 month after the vitrectomy for the proliferative diabetic retinopathy with and without adjunctive use of anti-VEGF pre-op. So this was a prospective randomized case control basically study. It was a cross-sectional study of 217 eyes. The inclusion criteria was of course PDR with vitreous hemorrhage, and exclusion criteria was eyes with macular tractional detachment with coexisting retinal vein occlusion, etc. So these were evaluated with SD-OCT, and qualitative and quantitative characteristics of SD-OCT such as ELM, ellipsoid zone, epiretinal membrane involving the fovea, hyperreflective foci, etc. were analyzed. So group 1 consisted of 107 eyes which underwent 23 gauge vitrectomy with addition of anti-VEGF, And group 2, 110 eyes did not receive any anti-VEGF preoperatively. All the eyes underwent MIVS. Now, if you look at the results, it will be interesting to note that the important parameters such as center involving DME was more in the no anti-VEGF group, as also the external limiting membrane disruption, etc., and the central macular thickness was also more in the no anti-VEGF group. So age-sex ratios were similar. Visual performance in the two groups and macular thickness was statistically analyzed, and the t-test difference was statistically found to be significant. The eyes with disrupted ellipsoid zone were noted to have statistically poorer visual acuity in both the groups. So this is the representative OCT 1 month after the procedure, but it's interesting to remember that this is just the beginning, because these PDR patients will have to have repeat OCTs and maybe many anti-VEGFs or steroids down the line. So studies that have reported anti-VEGF agents have mostly concentrated on use for intraoperative reasons and not for postoperative evaluation. So center involving macular edema was less with anti-VEGF in this study. Clinically exudates were more without anti-VEGF, and we also reduce the heterogeneity of the cases. We did not take up patients with macular TRD. So to conclude, to our knowledge, this is the first study to look at macular status with OCT at 1 month following vitrectomy with PDR for vitreous hemorrhage, and judicious use of anti-VEGF therefore before vitrectomy in diabetic PDR can help reduce surgical complications and also preserve better macular anatomy and give back better vision to the patient later on. Thank you for your kind attention.
Thank you.
See, you did not take the pre-operative condition of the macula before surgery. How do you assess then?
So because it's
and how do you let me finish? How do you check the bias in this case?
well, firstly,
Selection bias.
yes, sir. Firstly, the preoperative assessment of the macula is not possible because these are vitreous hemorrhage cases. So there could be inherent defect in that. But having said that, these were cases that were evaluated with ultrasound, and like I have mentioned, that cases which showed a tractional detachment or cases which had some peripapillary membranes over the macula were not taken up. So that was an ultrasound exclusion. And post-operatively, what we also intraoperatively, we excluded some patients, like I have mentioned, like patients who had coexisting BRVO, tractional edema, which was not evident on ultrasound, but was evident intraoperatively. These were cases that were excluded to find out whether actually there was any difference, whether we use the anti-VEGF or not.
Abdullah, another point is that these are the cases where anti-VEGF given within 7 days
Pre-op.
or pre-op or intraoperative.
Actually pre-op only. These are
Pre-op.
not cases that
Okay.
were given
Now you have again done the OCT at 1 month.
in 1 month.
So anyway, up to 1 month, suppose there is macular edema. So up to 1 month there will be less edema. The anti-VEGF will work maybe. Suppose if still you are not using for the purpose of macular edema reduction, suppose it theoretically you see till 1 month the effect is there. So after 1 month again the condition will be same.
Absolutely. Actually, that was not part of the study, but we have seen that subsequent to PDRs undergoing vitrectomy, in most cases, after a period of 2-3 months, many of these cases need either steroids or anti-VEGFs, and this is a recurring process. So the idea behind was to evaluate the macula and find out which are the cases that really need to be sort of followed at more frequent intervals.
Do you have a fixed protocol in your center for all the diabetic patients?
Absolutely, absolutely.
Thank
Okay,
you.
Thank you.
Next presenter, Dr. Shambhu Prasad Ghosh.
Good afternoon, everyone. I'll present a study to compare the ILM peeling and inverted ILM flap technique for large macular holes. A full thickness macular hole is defined as the anatomic defect in the fovea featuring interruption of all luminal layers of from internal limiting membrane to the RPE. The current strategy for small macular holes or less than 400 is doing a pars plana vitrectomy and ILM peeling. In my study, I'll show the results of inverted ILM peeling with simple ILM peeling technique and compare them for large macular holes. This is a retrospective comparative study of 60 eyes with the patient has idiopathic macular hole measuring more than 400 microns, and we followed the patient up to 6 months, which was included in the study. Group A underwent the internal limiting membrane and inverted flap, and group B only went for internal limiting membrane peeling with or without phacoemulsification and intraocular lens implantation. As a result, we see this is a retrospective comparative study of 60 eyes. Both groups have been compared with age, sex, and by their cataract status, which shows no significant difference by chi-square and t-test. The outcome from both the groups, from the preoperative best corrected visual acuity with post-visual best corrected visual acuity, was significantly significant. But in the but if we see the percentage of change, we see in the group A, which has undergone inverted ILM flap, has 70% of the cases have improvement of more than 50%, while group B only have 25% of the cases, which shows 50% or more changes. If we go by the size of the macular hole, which is from 634 to 1076, the group A shows a significant difference of the vision changes. But in the hole size measuring from 1076 to 1560 microns, the difference was not there. As a discussion, we could say that Michalowski et al. Has given us a very good technique of inverted ILM flap technique, which aims to eliminate the anterior posterior traction, extend the retinal surface by removing all cortical, vitreous, and surface components of the retina, while stimulating the cell migration and proliferation of glial cells into the macular hole, which definitely gives the better chances and potential to improve the postoperative visual acuity. As a conclusion, the inverted ILM flap technique appeared to be a safe and successful approach for management of large macular holes with promising anatomical results. Thank you.
Thank you. Basically, this ILM inverted flap technique is it is established.
Yes.
So
Yes.
this is something not very new.
Yeah.
But anyway, why do you feel? What is the hypothesis behind more successful? Though you have seen 70% cases, is it?
We are seeing the percentage of patients having improvement were more in group A.
70% in your cases?
Yes.
But many studies shown is almost 100% if you do inverted flap technique.
Yeah.
That means still your study has shown that it is not that excellent.
Yeah.
But still my question is not that. Question, what is your hypothesis? Why it is more
It
effective?
reduces the traction on the retina, the tangential tractions, all vitreous tractions on the retina, makes a bridging between the points of the macular and
What is the hypothesis in ILM peeling? What is the hypothesis in ILM inversion? There should be some difference, no?
yeah, the nuclear cells proliferations are seen better, which gives the space, it occupies the space and gives the better healing, and we get a post-operative, we get a primary hole closures, chances are better.
Okay.
There are different techniques of macular hole surgeries.
Yes.
You have tried between the two.
Yeah.
Okay, the without flap or with flap.
Yes.
That's it, isn't it?
Yes.
Okay. So did you compare with any other studies elsewhere? Is this the original study of yours, or have you compared it with some other studies as well?
No, we make this.
Have you
study-
compared your study? Was it compared? Did you compare it with any other? Do you get my question? What I
Yeah,
mean?
Yes, yes, yes.
So sir has also asked the same
Yes,
thing. So
yes.
that's quite striking in your presentation. The second thing is that what we want a glial tissue proliferation and to seal the hole,
Yes.
right? So whatever you do, either you place a free flap or you place an inverted flap, both the things will work the same way, isn't it?
Yes.
Placing the free flap is slightly difficult. Placing the inverted flap is much more easier. Okay?
Yes.
I believe so. That's it.
Thank you.
Thank you so much. Thank you. Next presenter, Dr. Bridges. Dr. Bridges. Dr. Bridges is present here. Okay. So we'll go to the next presenter, Dr. Joy Seth. And who is going to present instead of, yeah, you are going to present. Dr. Shruti? You are Dr.?
Purnima.
Dr. Purnima. Your name is not in that study, correct?
Sir, I'm actually the part of institute, so
No,
can
in
you
this,
just show the
Dr. Purnima, your name is not in that abstract, correct?
yes, sir.
Okay, anyway, you are presenting. Go ahead.
We may not.
So you can present.
Yeah.
present.
Okay, sir. My paper is on the long-term treatment outcome of the pachychoroid neovasculopathy, a real-world evidence in a Indian population. PCN is basically the delayed sequelae of the pachychoroid disease spectrum with the choroidal neovascular membrane without the polyp on the ICG. Its management is still evolving with the anti-VEGF treatment. So the aim of the study is to evaluate the 1-year outcome of the PCN with anti-VEGF monotherapy alone or in combination with the PDT and to assess the morphometric parameters on the SDOCT. It is the retrospective study of the 9 eyes divided into 2 groups, monotherapy and the combination, 6 eyes and 3 eyes respectively. So at the baseline, all patients underwent multimodal imaging including ICGA, DAFA, fundus autofluorescence, SDOCT, and the patient was followed up on the SDOCT. And the changes were the parameters observed were the best corrected visual acuity, SFCT, choroidal thickness at the pachyvessel, central macular thickness, SRF, IRF, and along with the shallow PAD height that we call as a double layer sign nowadays, with the height and the base of the DLS. And it was analyzed at the 12-month and with the final visit, whichever is the later. So the mean age of the patient was 69 years plus minus 7.29 years with the mean follow-up of 23 months. So the significant improvement was noted in the best corrected visual acuities, central subfield choroidal thickness at the pachyvessel, SMD height, and the DLS width. So to summarize my result, the 80% and the 44% of the eyes showed a complete resolution of the SRF and the IRF. The mean number of injection in all the patients was 5 injections. The average PDT spot size was 3,533 micrometer, and no significant difference was noted between the 2 groups in all these parameters. So this is a case of the pachychoroid neovasculopathy showing the SMD, increase presence of the pachyvessel shown by the red arrow, and the choroidal thickness increase at that level, and the ICG and the OCTA showing the similar configuration, and the occult picture on the DFA. So this is the more zoom in image of the ICG and OCTA. We can see a similar type of a network in both the case, in both the ICG and the OCTA. So at the baseline, the vision was 6/60 of this patient with the increased choroidal thickness and the pachyvessel. And after 1 month of the combination treatment, there was a complete resolution of the SRF and decrease in the choroidal thickness at the level of the pachyvessel and the subfoveally also. At the 3 month, the vision showed more improvement with the dry SRF PRF and decrease choroidal thickness and a decrease in the OCT angiographic network at the first month, and the reappearance at the third month, the BCVA, but the BCVA was maintained to 6/24 with the dry macula. So we are following this patient. This is the one more case with a similar presence of the double layer sign and the similar configuration
Please
of
summarize your.
similar combination on OCTA also. In zoom in image we can see. So this patient also, this is a monotherapy patient, and at the 12 month also the vision was like improving to 6/9, but the early recurrence with a late recurrence noted at the 18 month of the follow-up, but the vision is improving to 6/18 after post 6 intravitreal injection. So what was known was that the Perez and et al. Have demonstrated the reduction in the choroidal thickness without visual acuity improvement, whereas the Matsumoto et al. Showed the treat and extend aflibercept treatment, which improves the BCVA CMT choroidal thickness at the 2 years of the study. So what this study basically adds is like both the group shows the BCVA improvement and promising response in the choroidal and the retinal morphometric parameters with the PRN regimen, reduction in the choroidal thickness at the pachyvessel, and establishing the role of the photodynamic therapy in the patient with the pachychoroid neovasculopathy. So in a real world scenario, the treatment of the PCN with either anti-VEGF monotherapy or in combination with the PDT showed a good efficacy with the improvement in the base corrected visual acuity at the 12 month and promising morphometric parameters like promising improvement in the PED height and width with the choroidal thickness reduction. Thank you.
Okay. Thank you.
Thank you. Do we have to evaluate her?
Anyway, you can ask.
Okay. So I didn't listen to her data actually.
Okay. Are you a AOS member?
Yes, sir, I am a.
You are a ratified member?
Yes, sir.
You are a ratified member.
Yes.
Can you tell me the membership number?
Sir, it's P.
Anyway, you will
can
give
I
us the
just-
number, then we will decide. about
Okay.
the-
Yes,
And you tell me what anti-VEGF did you use
Sir, ranibizumab.
in all of these cases?
Yes, sir.
So this combined treatment was better or only anti-VEGF was better?
Sir, means they found a similar result in both the group. No significant difference in both the group was there. So we are still following this study with more number of patients to establish the role of PDT in patient with the PCN, sir.
Because whatever is seen in your result, so if it is the situation, then why people should go for combined therapy? rather than
Sir,
people go for
actually,
anti-VEGF?
now we
single
have
therapy?
just 9 eyes with so better more number of the study population, so we can follow up them, so we may get the significant difference.
Okay, thank you. Please continue the study. Let us see what comes.
Yes,
Thank you. So you give us your.
I will.
ALS
I'll
number.
just give you. Yes, sir. Okay, thank.
Okay, thank you.
sir.
She is not the presenting author, she is the presenting author, now only came to know.
Let us put marks. We'll write. Yeah, we'll write the AIOS number of her. Okay. So next will be Mehul Ashwin Kumar Shah. Mehul. No, he's not there. Purnima Nanda. So I thought we do not have to evaluate.
Which one?
The last presentation, I thought that we may not have to evaluate.
Anyway, we'll see that.
P209.
2098.
A very good afternoon to you all. My study is on ocular morbidity in acid-burn patients in a tertiary care hospital.
Okay, let
Coming to the introduction, chemical injuries of the eye may produce extensive damage to ocular surface, conjunctiva, corneal epithelium, stroma, sclera, eyelids, resulting in permanent unilateral or bilateral visual impairment. pathophysiological events was that which may influence the final visual outcome and which are amenable to therapeutic modulation include ocular surface injuries and repair, stromal injury repair, and ulceration. Coming to the materials and methods, it is a prospective study of acid-burn patients who presented to RIO between August 17 to January 18 of 2018, followed up for till 3 months. They were subjected to slit lamp evaluation, fluorescence staining, TBUT, fundoscopic examination, IOP measurement, and gonioscopic evaluation. The patients with history of diabetes mellitus and hypertension, pseudophakia were excluded from the study. Among the 29 patients with acid-burn injury in their eyes, 22 patients were victims of accidental acid burn while working in a acid factory. 4 suffered acid burn during household work, and the rest 3 are homicidal victims within age 18 to 30 years. Among the 26 patients, the 20 were males and the 6 were females. 44 eyes of 29 patients with acid burn were assessed using Roper Hall classification. At the time of presentation, visual acuity was less than 6/16 in 5 eyes, and in between 6 to 6/18 it was 20 eyes, and 6/12 to 6/9 it was 18 eyes. On examination, limbal ischemia was found in 70% of patients, corneal haze in 58%, stromal haze in 30% patients, and corneal opacity was found in 10% eyes. Grading of ocular burns were done according to Roper Hall classification. The eyes which presented with grade 1 injuries were 20 eyes, accounting for 45.5%, grade 2 with 12 eyes, 27.2%, and grade 3 with 7 eyes, 15.9%, and grade 4, the 5 eyes, accounting for 1.4% of the total patients. It was seen that during follow-up of visual acuity improved in 16 eyes, corneal opacity was found in 13 eyes, and symblepharon occurred in 6 eyes. The 4 eyes were referred for keratoplasty to the Haier Center, and VA remains still less than 6/16 in 5 eyes. Coming to the discussion, the sequelae of ocular burn can be severe and particularly challenging to manage. So immediately following acid injury, it is important to estimate and clinically grade the severity of limbal stem cells injury by assessing the limbal cell ischemia. Early vigorous irrigation with balanced salt solution or with normal saline is critical in limiting the duration of chemical contact with the eye. Immediate therapy is indicated towards prompt irrigation and removal of any reservoir of acid contact with the eye. The acid-burn patients were presented immediately after the incident, and those who had thorough irrigation of their eyes prior to the coming to the hospital has had good visual prognosis and less ocular morbidity as compared to those who presented late. It was also found that those patients who were referred with complications had poor visual outcome. My study was compared with another study which was carried out by Dr. Subudhi et al. In southern belt of Odisha. They also found those patients who had presented late with complications. They landed in grade 4, just near to my study. They account for the 12.5%. Thank you.
Thank you.
Your results, I could not make out from your presentation that your results were compared with the severity of the disease.
Yeah. It was
Like for keratoplasty or some number of things like that. What kind of grading of that disease was there?
the disease was graded according to the Roper Hall classification.
No, what I mean is the outcome
The
or the process. You have not given any comparative thing that this was the presenting problem and this is the outcome.
Yeah, actually I have given a slide where the visual acuity after 3 months of treatment, it was seen that those patients who presented at the, to us with visual acuity less than 6/60 and with corneal opacity, total corneal, they did not improve during our treatment, and they were referred to keratoplasty, and those number of eyes were 5 initially, and they were referred for keratoplasty.
Did you get my point? Did you get my question? Anyways, thank you, sir. You ask your question.
I know you are not going to Thank you so much. May I call upon the next speaker, Dr. Awasti?
Shall I start, sir?
Yeah, you start.
Yeah. Good afternoon, everyone. Today I'm going to present my topic on post-traumatic endophthalmitis and the trends changing. And I would like to thank All India Conference for giving me this opportunity. Post-traumatic endophthalmitis comprises around 25 to 30% of all cases of endophthalmitis, and the clinical course and results are dependent on various factors that has been listed by the Cohen et al. In a ocular trauma score, and he has defined that lesser this score, poorer is the prognosis. And there is a role of intravitreal antimicrobials in the treatment of any category of endophthalmitis. And the most common regimen that we use for the bacterial endophthalmitis is the vancomycin and the ceftazidime combination. And for the fungal endophthalmitis is usually the voriconazole that we use. But way back in 1999, Zelali et al. Has reported the increasing resistance for the ceftazidime and also a little resistance to the vancomycin. So with this basic background, we have planned this study to find out the causes and specifically the traumatic endophthalmitis and their causative organisms, and to find out the antibiotic susceptibility and the resistance pattern. And it was a retrospective study in which we have analyzed 46 patients of post-traumatic endophthalmitis suspect, and we have done antibiotic sensitivity with Kirby-Dish diffusion method. Most of the patients were younger age and the males, and the mean duration since trauma was 10 days, and 76% patients presented within 1 week. Presenting vision was very less from the perception of light to 1/60, but the final visual outcome in our set of patients was good, around from more than 20/200 to more than 20/40 was we have achieved as in 41% of the patients. But we have also found non-perception of light in 2 patients, in which one patient was eviscerated, in which we have found a mixed organism growth. And if we found about the culture reports, 22 cases were culture proven, out of which 50% were the gram-positive bacilli. And the most common organism that has grown was the streptococcus and the pseudomonas, as far as the gram-positive and the gram-negative were concerned. And the aspergillus was the most common fungi that has grown. It has been reported by Jalali et al. Also. And if we talk about the resistance for the empirical regimen, we have found a surprisingly very high resistance for ceftazidime that has reached up to 75% in our set of the patient. And this trend of increasing resistance we have found since 2016 to 2018. And this is the most alarming factor that we have found in our series, that one patient which has gone for the Proteus was resistant to colistin. This is like and if we talk about the other patients, so we have found resistance to iron antibiotics. The resistance to gram-negative organism has already been reported by several authors, including the ceftazidime and the vancomycin, but more for the ceftazidime. But the resistance for higher-end antibiotics has never been reported except for the systemic antibiotics. So maybe future studies will be required to validate our findings. So just to conclude, the most common isolated organism in post-traumatic endophthalmitis is the gram-positive organisms, and the antibiotic resistance and susceptibility pattern is changing, specifically for the ceftazidime. So maybe in the future we need to change our empirical regimen, and the higher-end antibiotics should be kept for the reserved cases. Thank you.
Nice presentation.
Thank you, sir.
You talk about the antibiotic resistance. You did not talk or mention about the type of trauma these patients sustain.
Basically, sir,
Because why I asked this question, because different type of trauma would
will have different type of
different
prognosis.
type of organisms.
Yes, sir.
Absolutely. And 50% of your traumatic endophthalmitis out of 22 where the
Gram
cancer was-
positive.
gram positive. So still the gram positive is high in your
Yeah,
study.
in our series also, sir.
Okay. So how you compare with other post-traumatic end of case studies?
So most of the studies have reported the gram positive to be on higher side. Even most of the end of thelmitis series, not even the post-traumatic, all series have reported the higher prevalence of gram positive
Let
organisms.
us specific to the post-traumatic.
So they most the studies have reported the higher incidence of gram positive organisms.
Yes.
Specifically the streptococcus and the staphylococcus if we talk about the combination.
And what about the vancomycin resistance in your series?
So we have not found any case for the vancomycin resistance, but the literature says so.
So in your study, mostly gram positive, and there is no vancomycin resistance. So ideally, the improvement should be there.
Yeah,
not
maybe that's why this is the reason we have found a very better visual results. So most of the patient, 40% patient recovered good vision.
And why no PL in these two cases?
So one was the mixed organism and one was like a large tear. It was almost collapsed
So
type
this
of.
is so in one case you feel this is related to the infection.
Yeah, and
In
other was
case not related to the infection.
not related to the infection, it's related to the traumatic
Anyway,
level.
This is very difficult to
Yeah,
see,
Yeah.
analyze. Anyway, thank you so much.
Thank
There
you,
are
sir.
many variables in your studies, and maybe they have not been neutralized that way.
Maybe, sir. Thank you, sir.
Okay, next presenter, Dr. Anisa Sakma. Yes.
A very good afternoon to everyone. My name is Dr. Anvesha Chakma, and through my presentation today, I want to share a case which we came across in Mahatma Gandhi Institute of Medical Sciences, Sevagram Wardha in Maharashtra, which is a tertiary care hospital in a rural area of Maharashtra. So it's a case of canalicular tear repair performed in rural setup using 22-gauge intravenous cannula as a stent. So nowadays, ocular adnexal injuries, including canalicular tear, are most commonly encountered by ophthalmologists. Most common cause being the dog bite injuries, and other being accidental fall, road traffic accidents, and most commonly found thus blouse hook injuries in breastfed infants. It's very important to repair the injuries within a short period of time, the lead tear as well as the canalicular tear, to maintain the anatomical structure and physiological function of the lacrimal drainage system. Stents are used in repair of canalicular tear in an attempt to maintain proper alignment of the anastomosis and to prevent post-laceration strictures. So repair can be done within 5 days with successful outcome. In my case, a 31-year-old male with full thickness lower lid injury with no canalicular tear in right eye following a road traffic accident admitted in a hospital which is situated in a rural area. His visual acuity recorded for distance was 6/6 with PR accurate and the globe was not involved. Left eye was normal. The patient was taken to OT after 3 hours of his admission, and surgery was performed under local anesthesia. The cut ends of the canalicular were identified. The punctum dilatation performed with Nettelship punctum dilator. A 22-gauge intravenous cannula was threaded over its needle, and the canalicular tear site was bridged. The subcutaneous tissue was sutured with 60 Vicryl, and the skin was sutured with 50 silk layer-wise. Other ocular injuries were examined, which were not there. So this is the pre-op photograph of the patient with lower tear as well as the lower canalicular tear. The qualities of an ideal stent are they should be inert, soft and pliable to minimize the ocular irritation or tissue reaction. They should be stable enough to remain in the place along until pericanalicular inflammation subside. Silicone stent meet all these qualities. Mini monoca is the most commonly monocanalicular used stents nowadays. So in our case, procuring a silicone stent needed more than 2 days time and also more money. Then cannula anchoring skin stitch broke at 1 week, else patient recovery was uneventful. The cannula was removed at 4 weeks, and syringing was confirmed by, patent by syringing. This is the post-operative photograph of the patient. So on the discussion, the several authors propose that early intervention of 9 to 32 hours is the key to success to canalicular tear repair. 20-gauge silicone tube offers a significant cost advantage to standard monocanalicular stents. Microscopic canalicular reconstruction with mini monoca is soft, reliable, and simple technique which is preferred in tertiary centers nowadays. So to conclude, in a rural setup, an indigenous solution saves not just money but precious time to the primary repair of the critical canalicular wounds. But however, the procedure is more difficult and its long-term failure rate needs to be evaluated. Thank you so much.
Thank you. You have tried something new. Can you just explain again the exact procedure, what you do, 23 gauge, how you do that?
Sir, basically after identification of the wound, we have to find the two ends so that we can bridge the wound. So after because punctum was not involved, so we took the 22 gauge cannula, and we 60 vically passed through the cannula, and we passed to the punctum and anchored it with the superior punctum.
What is the difference between the mini monoca stent or silicone and your device?
So basically, silicone is the most preferred material to be used here, but as we're in a rural hospital where patients come from very interiors, so they cannot afford mini monoca or silicone tubes, so it was a cost-effective emergency.
So basically you are using 22 gauge?
Intravenous Vasofixer, Venflons, IV cannula, sir.
IV?
Yes,
Okay.
yes.
What is that material?
That is a nylon, I think so.
It's a mixture of nylon and plastic.
Anyway.
No, but one thing is there that whenever you use that IV cannula elsewhere, it
Yes,
gets
sir.
blocked.
Yeah.
How often
sometimes.
did you do those syringing? Immediately after surgery or sometime later?
So
And could you dislodge the block if it was?
Sir, actually, during my senior residency, I came across only 4 to 5 cases which we operated. On first week, we did the syringing.
First week?
Yeah,
But if it
first
was
week.
blocked, could you dislodge the block?
No,
block.
properly, no, sir.
No block.
And we could not dislodge the block, actually.
So it remained blocked.
Yeah, that disadvantage is there, sir.
Mm. And how long can you leave that cannula in that place?
So usually, mini monoca we remove after 3 months. 6 weeks to 3 months. But in this case, we remove the cannula within 4 weeks because it causes sometimes irritation to the patient because it can poke the skin outside. So sometimes patient comes.
Extrusion is the major
sir,
problem
yes,
with them.
Yes.
And they are quite stiff, not
Yes.
like silicone. These
Yes,
cannulas
yes,
are
sir.
very stiff.
Yes,
You
yes.
cannot bend it. Suppose there is a very, it is not aligned. If the tear is not aligned, you cannot just pass like this
Yes, yes,
because
sir.
it's
Yes.
not flexible like the
Yes,
silicone
yes,
tube.
sir.
So there are
Yes.
practical problems as well.
Yes, sir.
The other thing is that sometimes when you do these stenting,
Yes, sir.
the blockage is beyond the stent. How far did you go with your stent?
So
Was it just bridging it?
Yeah,
If it
it
just
was-
bridges it, there is a blockage sometime beyond it.
yes, sir. It was just bridging, anchoring kind of thing, sir.
Okay,
Okay.
thank you.
Thank you so much.
So let me again repeat whether the previous speaker were absent there. Dr. Partho Rana, you have come? Okay, please come. Partho Rana.
वीडियो देख लीजिए इसमें हो जाएगा जिस पीछे पेन ड्राइव ये रही पेन ड्राइव लगी हुई है यार मैडम
अरे सर आपने ऐसे कैसे पेन ड्राइव लगा दी
Till the last presentation.
If the other two
बताते ना
will see.
Mehul.
लगा रहे थे लोग।
Only Mehul. Yeah.
स्क्लेरोटाइड
PAURNIMA.
बताइए
स्क्लेरल का
HANKAR.
यस
Okay.
इसके ये वाला हाँ, नीचे वाला
ये
Bandhakar.
एंटर कर दीजिए।
डायरेक्ट नहीं चला सकते
BONDHAKAR.
अच्छा डायरेक्ट नहीं चलेगा।
मैं नहीं चला
BO
BODHANKAR. ANKAR.
1 मिनट You want-
वीडियो चला दीजिए, वीडियो चला दीजिए।
आपका पीपीटी में नहीं है क्या ये?
पीपीटी में है पर ये
Is Mr. Brijesh Thakkar here?
क्यों नहीं चलेगा सर?
अरे
No.
इसमें आप वीडियो चला दीजिए, आप कह रहा हूँ उसमें करेंगे।
उसमें तो पीपीटी है ना आपके
सिर्फ
उसमें?
वीडियो चला दो और कुछ नहीं करना।
आप मेरे हैंग करवाओगे, आप और कुछ नहीं करवाओगे।
यार ये नहीं करो, नीचे है भाई, छोड़ दो एक
आप
मिनट, एक मिनट।
मैं कर रहा हूँ, ऐसे ही हैंग हो जाएगा लैपटॉप डायरेक्ट चला के। आप तो घर भी चले जाओगे।
पोस्ट करो।
Good afternoon, everyone. I am presenting scleral tuck IOL, that is plan B for all the cataract surgeries, especially for retina people. This is my patented design. It's patented by me and Dr. Mehul Shah. I have video-based presentation. Sound. Sound. लैपटॉप में साउंड नहीं है. When we are doing cataract surgery and when there's a nucleus drop, there's no support for posterior capsule, then we are in soup, but not anymore. This is my patented design of scleral tuck IOL. It is self-sustaining scleral tuck IOL. It doesn't need any suture or glue with it. These are the previous designs of IOL, and this is the evolution. When 3-piece IOL came, then with eyelets, and finally this is a basically new design with flippers. This scleral tuck IOL is made of totally 3 parts. There's an optic, haptic, and a flipper. This optic, this is designed by price tag label, which price tag label, it doesn't come out just like that. When we pull it out of 20 gauge, it doesn't go back. These are the total parts, and flipper, it's the main part. It's a major innovative idea, and it's a crucial design. When we pull it out of 20 gauge sclerotomy, it doesn't go inside. It's thick and partially rigid. And it is an eyelid. So in case of unsureties, we can suture it, and we can pull out flipper with this vitreous forceps. Also, we can pull it out. And this flipper is larger than 20 gauge sclerotomies. So once it is out, it can't go back. It's horizontally larger and vertically smaller. We can see after this animation. And this neck is size of 20 gauge. So when we are pulling out this flipper, this neck stays at 20 gauge sclerotomy, and fibrosis happens near neck. And it is a bit stretchable also. So when we are pulling out flipper, it gets stretched. And these are the haptics. These haptics are stretchable, and it can take shape accordingly, and it's 4-point fixated. So in case if when we are pulling it out, one haptic breaks, other haptic can take the charge. And due to 4-point fixation, it is highly stable, and pseudophacodonosis is very minimal. And optic, optic is also foldable, and it is 6 millimeter in size, and it is large enough to cover even a mesopic pupil, and even a case of misalignment of sclerotomies. And it is foldable and can be easily inserted through phaco main port. We are under process and making of injector. This is animation video. This is the main port, and these are the side ports. Normally in phaco case, we get it already made. We are injecting the this IOL on the iris and then rotating it horizontally, and with handshake technique, with dialer and forceps, or both the forceps, we can just pull it below the iris and pull it out from the 20 gauge sclerotomy made under the scleral flaps. And same thing is repeated on the other side. And it is stretchable, and it's made of foldable material, so it's quite easy. Okay. Thank you.
Thank you. Do you have any surgical video which exactly showed that other than the animation?
It is there. It is there, but time is gone. So if you want, I can play it.
Let me just check first whether other presenters are there or not. Dr. Brijesh.
No, he isn't there. I just asked.
Dr. Brijesh and the other one. Dr. Mehul. So he's
No,
the last
no,
one.
he's the
You
last
can
one.
show us the video.
You can
Okay.
show us the video, yes.
This is the video. This was a trauma case, and it was a bit hypotonic eye. And in trauma cases, and especially in cases where already a surgery has happened, we usually don't prefer to use visco. So we kept an infusion cannula. We cleaned whatever cortex and other capsule was left. Then we made an entry. Right now we have made an entry with 5.2 because we have not made an injector, but it is foldable. And when an injector is ready, we can definitely do it with phaco port. And this is, we are injecting it in anterior chamber. And this, we are pulling it out. This, you can, as you can see, this flipper is out, and you can see how stretchable it is. And this, finally, we did a suture for conjunctiva, but it is not needed. Like if you have a small clot, you can just place it below the conjunctiva and just keep it like that for a minute, and it stays like that, same as what we do in pterygiums. And we don't use suture, glue or anything, and it is highly cost effective, and it takes hardly 10 minutes after any complication. You don't have to search for a glue, 3-piece IOL, or you don't have to make tunnels and everything. No sutures, no tangling between sutures and all. It's quite simple, just 10 minutes and it's over.
Shall I ask some questions? Look, I have witnessed your video in the VRSI at Bhubaneswar.
Oh, okay.
Okay. And there are 2-3 things that you should understand.
Yes, sir.
The point one, that whosoever does a scleral fixation IOL, now nobody uses sutures now. Very few of them are using sutures. They are just exercising the haptics. A foldable IOL with a C-loop haptic, it comes out with a 26G needle.
Yes, sir.
Okay, without making any incision, any sclerotomy for that matter. You just make a tunnel, pull out those haptics. Looks even simpler than what you showed us. And it is feasible in any of the eyes, point one. Point two, and the important part is that these foldable lenses, we have a library of these lenses in our OTs. Probably once you make it, once you market it, we'll have to have the new kind of library with these lenses, but that's a routine library that everybody has in their OTs.
True, sir.
Point two. Point 3. Have you ever tried this in large myopic eyes?
Yes, sir. We have tried in -20. Patient came with us. Actually, I was working in Dahod. There's a tribal area, and there's a high trauma cases there. And there we implanted in -20 case, and there were no issue because actually it is stretchable. It's stretching by itself, and there was a minor astigmatism after that because it was pulling the sclera a little bit. There was but astigmatism was also we were able to correct.
So till now you do not have the injector. So
Yeah, we don't have an injector because we are mainly like in that center we were mainly doing SICS. Until now they are doing mainly SICS, so they didn't need it.
It will
but
be useful only if you have an injector because you are making it a foldable lens. And again, you are using the 20 gauge MVR blade to make the opening.
Yes, sir.
And you are pulling out from this. So usually 20 gauge means, is there no leakage?
No, sir, because this neck is at size of 20 gauge, and what happens? This haptic is like rectangular. So when it is pulling back, so it is blocking the sclerotomy, and we have a scleral flap above that, and above that there's a conjunctiva. So we were ourselves we were worried there are chances of infection, but we never find, and that too in tribal cases where hygiene is too bad. We never find a case of endophthalmitis.
How
in this.
this lens is straight? Because it's a, is there any angulation?
No, simple thing like how we have a price tag, like price tag on a label. There's a T point there, and it comes out of a tiny circle. So when you pull out like that, you have to tear the paper. Then only it comes out. It's same like it's when we are pulling it back. There's a sclera and there's a intraocular pressure which pulls it back. So we never had an
What
issue
I am
like that.
asking, suppose, is it not mounting below the conjunctiva? That I am asking.
No, sir. It has never happened. Actually, it is its size is 13.5.
Because if you just see the configuration of the eyeball, ideally this the outer part should be curved,
Yeah,
aligned with the sclera.
true, sir.
But this is a straight lens.
Straight lens,
So this should have a tenting effect over the conjunctiva.
not conjunctiva. We have a scleral flap above that. If you saw in video, there's a scleral flap. So it is pressing it's pressed by scleral flap, and we
Do
have
you suture the scleral flap? Your scleral flaps were quite big
yeah, we are not suturing
and
scleral
open
flap.
from all sides, attached to the limbar part only.
Yeah, but we are not suturing that. It
So
gets
that is the
fibrosed by
point
itself.
actually. If you are not suturing that, is it not making a tent-like effect?
We have around 8 months follow-up. Like few days ago only, we got
Just
a
look into that matter.
yeah, we got a 8 months follow-up, and it has fibrosed by itself.
I have modified my system. I'll tell you how.
Anyway, thank you so much.
Yep.
So, if the other presenters are not there, we will conclude the session here. Okay. So I thank my colleague, Dr. Rajesh, and
Thank you, sir.
I think we can have a little bit regarding this. Tell the other people also.
So if you
Dr.
if you go with the technique which I follow, the exteriorizing of the haptics, if you are interested, I can tell you. Like if I am sitting here, and if there is a, if you could see, this is the phaco opening here. I make a tunnel like this. Okay, I make a long tunnel like this. I enter from here. I make a tunnel like this, and I make a tunnel like this. Okay, so these are the two. I don't open it. It's just an opening. I just go from here and make a tunnel like this, just a pocket. Okay, I inject the C-loop 3-piece lens, and from here I go with a 26G needle here into this vitreous cavity, and from here into this. Okay, and I with the force and I just insert that haptic into the 26G needle, and I pull it out. So this automatically, this haptic goes under the sclera. There is no need of tucking it under the sclera or whatever. Keratome. Normal keratome tunnel, you make it, you enter from here, end of the tunnel. Okay, which should be at the 3 and 9 o'clock position. You just go from here. How big is your tunnel is lengthy. I make it quite lengthy so that the haptic is not, exteriorized mostly. Okay, it is not subconjunctival anyway. It should be subscleral. Okay, and similarly here. And what I do, I just, if something a bit longer is out, I just bend it with the cautery. You just bend it and you can just leave it there itself. Yeah. So it takes not more than 10 minutes to do a scleral fixation lens. That's it. And it is these lenses are always available in our library. These are bent needles. Yeah, through the tunnel and like this. Normal, you just normal bend. You just bend. You can start from here. You can start your needle from here and just go in like this, and you just enter and just pull it out. It exteriorizes, and from here it's a very simple process. The whole procedure doesn't take more than 10 minutes. You have done a vitrectomy, it takes 10 minutes, nothing else.
Rather than the straight opening, sir is making a tunnel.
Tunnel. Whatever eyes, no problem. Because you are not going like this, you are going like this.